Welcome again. This session is about kidney disease in the era of COVID. Our first speaker is Professor Adel Afifi, Professor of Nephrology at Shams University. He is a creative of the National Kidney Foundation in Egypt. He's the first to have the Egyptian registry of hemodialysis. Professor Adel will speak today about EKI in the era of COVID-19.
Good morning. Today I'm going to talk about COVID-19 induced acute kidney injury. Acute kidney injury has been reported in up to 25% of patients infected with COVID virus. There are several mechanisms that can cause acute kidney injury in COVID-19 infection. Non-specific perirenal azotemia, tubular injury, interstitial nephritis, vascular injury, glomerular injury. Several studies have highlighted changes in urinary sediment, including proteinuria and hematuria, and evidence of urinary excretion of COVID virus, suggesting the presence of a renal reservoir for the virus. Angiotensin converting enzyme 2, or ACE2, has been confirmed to effectively bind to the S1 domain of the spike protein on COVID virus. Therefore, ACE2 is considered to be a functional receptor for SARS-CoV virus. Regarding the pathophysiology, there are non-specific mechanisms or direct cellular injury resulting from the viral entry through the receptor ACE2 or imbalanced renin-angiotensin-aldosterone system, pro-inflammatory cytokines, and the thrombotic events. Let us start with the non-specific perirenal azotemia. Excessive fluid loss due to severe vomiting and diarrhea that are well known to happen in COVID-19 infection. This is the first mechanism. Most COVID-19 patients with acute kidney injury are older and have frequent comorbidities such as hypertension or diabetes mellitus. These factors are well-known factors for renal vulnerability. Again, non-specific mechanisms include hemodynamic alterations, right-sided heart failure, high levels of PEEP in patients requiring mechanical ventilation, hypovolemia, administration of nephrotoxic drugs, and nosocomial sepsis. Again, impairment of gas exchange and severe hypoxemia has been recognized as factors associated with acute kidney injury in patients with ARDS. COVID-19 virus can directly infect the renal tubular epithelial cells and podocytes through an angiotensin converting enzyme 2 dependent pathway and cause mitochondrial dysfunction, acute tubular necrosis, the formation of protein reabsorption vacuoles, collapsing glomerulopathy, and protein leakage in Bowman's capsule. In this picture, you can see in A, which is on the left side, typical picture of acute tubular necrosis with shedding of tubular cells almost obstructing the tubular lumen. The same picture in B, and in C also the same picture, a luminal obstruction by debris from the degenerated tubular epithelial cells. In D, you can see a normal glomerulus, but beside it there is a tubule which is filled with RBCs. The arrow is showing the RBCs. And in E, you can see evidence of mitosis, indicating starting regeneration of renal tubular cells. Again, in this electron microscopy, you can see the virus particles inside the renal tubular epithelial cells, the red arrows, with the same typical picture with spikes. Proteinuria and hematuria occur both in COVID-19 infection. Proteinuria is reported in up to 63% of cases and hematuria in 26.7% of patients. Two types of proteinuria have been identified in COVID-19 infection. Mostly, proteinuria is of low abundance, which reads about 1 plus in urinary dipstick, and this probably reflects tubular injury. But in some cases, proteinuria is abundant or constituted with albumin, suggesting glomerular origin. Viral injury to the podocytes and renin-angiotensin system activation may have contributed to proteinuria. Accumulation of angiotensin II may be responsible for nephrin endocytosis and subsequently increased glomerular permeability with proteinuria. Again, increased kaliuresis. Patients with COVID-19 infection lose potassium in urine. 93% of hospitalized in ICU patients had hypokalemia at admission. Hypokalemia with increased kaliuresis as a marker of renin-angiotensin-aldosterone system activation was associated with the most severe forms of COVID infection requiring ICU admission. The third mechanism is interstitial nephritis, which is actually uncommon. Few cases of acute interstitial nephritis were reported due to viral infiltration, but it may also be induced by the drugs used to treat COVID infection, like lopinavir, ritonavir, remdesivir, favipiravir, and ivermectin. Any one of these can cause acute interstitial nephritis. Now let us go to vascular injury. Vascular injury. COVID infection triggers coagulation activation, leading to kidney vascular injury such as ischemic glomeruli and fibrinoid necrosis. Glomerular capillaries obstruction by the red blood cells has also been reported during COVID infection. There are vascular consequences for COVID infection, which leads to coagulopathy. The virus can cause capillary obstruction by red blood cells. It also can cause coagulation activation and also cause fibrinoid necrosis and glomerular ischemia. And this is a typical picture of thrombotic microangiopathy in a patient with COVID-19. The final mechanism is glomerular injury. Glomerular injury. First, you can find the histopathological findings related to the underlying conditions such as diabetes, hypertension, or cardiovascular disease. Again, you may have diffuse acute proximal tubular injury with cytoplasmic vacuoles, and this is the commonest form of acute kidney injury in COVID infection. There is also collapsing focal glomerulopathy. Diffuse erythrocyte aggregation and obstruction in the lumen of the glomerular and peritubular capillaries. Glomerular ischemia and endothelial cell injury. Myoglobin casts or cellular debris casts. You know that rhabdomyolysis has also been reported in patients with COVID-19 infection. Now let us come to this table about the treatment of the critically ill patient with acute kidney injury necessitating renal replacement therapy. It looks a very busy table, but I will try to enlarge it and make it much easier. Now, the indications to start renal replacement therapy in acute kidney injury in a patient with COVID-19 are oliguria with refractory hypervolemia, hyperkalemia, severe acidosis, and azotemia. But always remember that in the presence of cytokine release syndrome, you have to consider extracorporeal techniques for cytokine removal, even in the absence of acute kidney injury. And here comes the role of medium cutoff membranes and high cutoff membranes. Medium cutoff membranes have pores that are a little bit wider than those in the high flux membranes, so they can remove much more larger particles. High cutoff membranes are membranes with very big pores that can remove everything up to the size of albumin, which is 62,000 kilodalton. Now, I know these are not available in Egypt, but if they are available, you can start using them. Or you can use hemadsorption devices in special cases, and you can also consider the need for multiple organ support therapy, like extracorporeal carbon dioxide removal, or ECMO, which means extracorporeal membrane oxygenation, which is actually a modification of the artificial heart-lung machine, and it helps to provide the blood with the necessary oxygen to function. To prepare for this, you have to have a vascular access, at least 12.5 French, preferably used in the right jugular vein. And you have to ensure the availability of CRRT machine and all supplies, dialyzers, special membranes, and sorbents, and so on. In the prescription, it is better to select continuous renal replacement therapy as a preferred modality in the CVVH mode or CVVH-DF mode. And you have to have a blood flow more than 150 ml per minute. You have to use also citrate anticoagulation, or you can also use low molecular weight heparin. Citrate initial dose is 3.5 millimole per liter, or low molecular weight heparin in a dose of 3.5 milligram per hour. Prescribe the dose of CRRT at 25 to 30 ml per kilogram per hour, and targeting a minimum delivery of 20 to 25 ml per kilogram per hour. You have also to ensure catheter function, avoid recirculation, avoid filtration fraction more than 20%, calculate treatment downtime, match net ultrafiltration with other components of fluid balance, and you can change the filter every 24 hours if possible. Thank you.
Very much, Professor Dr. Adel Afifi, well illustrated, very comprehensive and up-to-date information. Thank you again. يلا حسين.
It's my pleasure and honor to introduce Professor Hala Al-Wakil, Professor of Internal Medicine and Nephrology, Alexandria University, and she is now the current chief of the nephrology unit. So I would like to congratulate her for this position. And also I would like to congratulate her, Professor Hala, for the success of NephroAlex.
Yeah,
Today, Professor Hala will give us a very exciting talk about the COVID crisis, and she will discuss advanced technology in COVID-19. Professor Hala.
Johnny M in the mix.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee and our dear brother, Dr. Magdi Sharqawi, who invited me for this elegant conference. And I would like to congratulate all the Ain Shams team for this nice and 12th conference. This task طلب مني الحقيقة when I'm interested in advanced technology in nephrology, especially in this era. So let us revise in the next 20 minutes this topic. The key advances in nephrology was published in Nature this year, and among these key publication was the artificial intelligence approach to improve kidney care. First, what is artificial intelligence? It's a field of science and engineering concerned with computational information that is referred to an intelligent behavior, and we have to use this intelligent behavior in development of an object or an outcome. The artificial intelligence is any technique that enables computers to mimic human intelligence using the logic, rules, decision tree, and machine learning. And the machine learning is a subset of artificial intelligence that includes statistical technique that enable machines, and so the name machine learning, that enable machines to improve tasks with experience. And from the machine learning, there is deep learning, which is a subset of the machine learning, composed of algorithms that permit software to train without machines, to train itself to perform tasks, and by the end of the day, there is a data and outcome, and we need from this to get an output in deep learning, have a vast amount of data. And this figure simplifies this issue. When there is a car in machine learning, we introduce the whole features one by one for thousands or millions of cars, the height, the width, the wheel, the window, all this through a machine, and then we compose each other together. And by the end of the day, we have to know that this is car when we are seeing this car. But the deep learning, we omit this machine and we introduce a lot of images for the car. Of course, the data should be in deep learning should be a high of greater amount than the machine learning, and by introducing this huge amount of data, the computer can know that this is car. What about the nephrologist and the use of this technology in nephrologists? We all know the omics, the proteomics, the genomics, the metabolomics, the microbiomic, all these issues that give us illustration for some disease or some pathology. And we put on it the clinical data, the demography, the immune system, the physical examination, the biopsy, the ultrasound, all these, and we put it. We classify this with this will make the diagnosis of that disease, and we put a lot of data for this to get the identification of the AKI. And then we put on it more and more the treatment so as to get more data about the optional treatment. So when we get a lot of data and reinforced learning, the output will be more and more clear. What about the patient-generated health data? When we put sensor data, some morbidity, some mortality, some data related to the outcome, we improve the recovery and the monitoring and the faith and the outcome more. This is a simple issue. I advise you to Google this very elegant review article about the use of artificial intelligence in kidney disease, and it summarized the all studies in 4 sectors: in alerting system, in diagnostic assistance, in guiding treatment, and evaluating prognosis. Starting with the alerting system, one of these very important alert systems that use artificial intelligence that used by the National Health Service in England in 2014. And they recommend the wide-scale introduction of and the uptake of an automated computer software algorithm to detect the AKI. And the Google conjoined with this project and put the stream projects. And from that time, the application of AI in AKI increase and more, and the studies increase more and more. It was very helpful in diagnosing AKI requiring dialysis and give us more than 90% of good results. But as you show, there are a lot of data introduced to get these results. Also, after post-cardiac surgery, the machine learning technique also gives us a good data in comparison with the traditional logistic regression from the statistical analysis. And this table shows a lot of studies for the artificial intelligence in AKI models. And coming to the alerting chronic kidney disease, from the progression point of view, but the work in CKD is much less than the AKI. But one of the very elegant studies was this model coming from Japan. They took the KDIGO data from 2009, 11, and 16, and put this pattern of algorithm so as a causality. This cause that, and this cause that, and by the end of the day, they found and put all these variables. And they conclude that the kidney function checkup is necessary to follow up not only patients high risk مش بس الهايبرتنسيف ومش بس الاوبيز ومش بس الميل ومش بس كذا، انما اللو ريسك برضو لان لقوا في variable data يعني لقوا في الداتا بتاع 2016 دي ظهرت outcome مختلف. فدي كانت الحقيقه من اكتر الحاجات اللي كانت very elegant في alerting CKD, and this is a lot of study in that issue. Coming to the diagnostic assistance, I will pick some of these studies, starting with the imaging. One of the elegant presentation in the field of polycystic kidney, they put this computer-aided diagnosis by CT, and this is a part of this is a deep learning. They put multiple serial of CT, and they found this is converted by this image, and they stored all these images, thousands and millions of films, so as when they put it, and they learn more and more, and when they put this, they conclude that this is a polycystic and this is the size of the kidney, and they follow the progression of the polycystic kidney. But there are fallacies, and this is an example of the fallacies. They found the liver cyst, they understand it as a kidney cyst. So this is some of the challenges of the artificial intelligence. For that reason, they use visualization. They have the human being to visualize first the film, and they put all these data in layer, and this form of technology called the convolutional neural networking. They pull and convolute, and then they make the data more refined and remove the images that are not good, and to get the final prediction model. As regard, and this is, they start, for example, in this study with 16,000 images and reach to 9,000 images because they remove the bad images so as to increase the sensitivity and the accuracy of this technique. What about the pathology? There are a great work in that field in the pathology because it depends a lot on subjective element. One of the elegant presentation in diagnosis of the renal interstitial fibrosis, because there is a lot of conflict between different pathologists in that field. They put this computer system, and they put a number for each of the components of the renal biopsy, for the healthy glomeruli, for the sclerosed glomeruli, for the arteries, and so on. And they learned the computer to label this, and then subtract those elements from the whole kidney to get the interstitial fibrosis. This is the idea of this technique. It's based on a computer training and testing. And this is a graph. It is somewhat complicated, but it shows it starts with each component. This is a tissue, the luminal and the cellular fluid, the tubular structure, and so on. And at the end of the day, they subtract, and the output is the interstitial fibrosis. They found in this paper that there is a great difference between 5 pathologists when they put the score for the interstitial fibrosis, but when the computer assists them and put score, the mean was almost not different so much from each other. And another field is ICD codes. This is not very evident and very poor in study بس الحقيقة حطوا كود عشان برضو فلقوا ال AUC in predicting acute renal failure وCKD. احنا عارفين ان ال AKI والCKD في ال ICD-10 مش موجود لهم ارقام، بس لقوا سموها دي ال ICD-11 ولقوا ال AUC بتاعت ال acute renal failure 0.9 and this is great, and for CKD is 0.9 also, and this is the value for the CKD and the AKI, and they found that the deep learning is much better than the simple logistic regression that is given by the normal يعني ordinary statistical model. What about the treatment? I pick just two models, the wearable dialysis devices, ويمكن الدكتور مجدي بيه يحب عارف الديفايس ده وهو كان interested in that فحبيت انا احطه له. It depends very much on a lot of technology. There is a smart t-shirt and smart watch, and there is this machine with a lot of biosensor for the patient that dialysate, so as to give them a lot of data. This is a model of big data. And there is artificial kidney with a scaffold for the glomeruli, the organoid, and the 3D bioprinting for the tubules. And there is these sensors in the t-shirt and the watch for the ECG, for the oxygen pulse oximeter, for the electrolytes to give alarm. And the dialysis box الفكرة كلها في الwater saving strategy عملوها كويس قوي والsorbent based technology عشان يخلوا الووتر قليل عشان ما يبقاش فيه كتير عشان يقدر يحمله على البوكس اللي هو بيشيله ده, والنانو تكنولوجي عشان يريموف البارتيكل in a very smart way مختلف عن اللي احنا عارفين. And the computer make this constellation of thinking and put this data locally and on a cloud, and every day there is this is يعني put it all the time. اتجربت على حاجات على اعداد صغيره بس شغل ماشي فيها كويس قوي في الفيلد ده. في فيلد تاني الحقيقه كان فيري نايس اللي هو الفيني بانكتشر ارتفيشال انتليجنس جايدنج يعني موديل, هو عشان بس الفيني بانكتشر والانجل ويدخل قد ايه والقصه دي. They put also a model for the venous mapping بالانجلز بالمسافه بينه وبين السكين and all these, and put all these data ويطلع 3D model so as to and as يعني connected with a robot so as to introduce the needle in the proper مش عارفه needle راحت فين in the proper this is a needle in the proper direction and the angle and then for the proper depth. The fourth field is evaluating prognosis, and I pick just one very simple model for this evaluating prognosis, IgE. IgE is the most common primary gene. فاستخدموا الجماعة الصينيين دول استخدموا random forest model, it's a model of the machine learning. استخدموه عشان يشوفوا يشوفوا which is going to progress to CKD to end stage. فلقوا البريدكتيف موديل قال ان الماست سكور والسي 3 staining والاستيميتد GFR are among the most accurate prognostic variables يعني. دي الحقيقه كانت لطيفه قوي. طلب مني ان انا اشوف الاي اي and artificial intelligence and COVID-19. الحقيقه هي الايرانيين شغالين قوي في الحته دي من قبل كده يعني في الحاجات الثانيه في النفرولوجي and artificial intelligence. دي ريفيو ارتكل. الحقيقه دي كانت احسن موديل اتطبق في الكوفيد 19. الموديل بتاع الارتفيشال انتليجنس دي من البالمونري سي تي حطوا بدوا ب 3000 حاله 3500 حاله مالتيبل سي تي ودخلوا برضو التريننج والتستنج والقصه دي عشان باي ذا اند اوف ذا داي يطلع هل ده كوفيد 19 ولا ده كوميونتي اكوايرد نيومونيا ولا نون نيومونيا. فده طبعا كان يعني بريك ثرو في الحته دي وبراكتيكال وايز. بس في تشالنجز طبعا بينج احنا كلينيشن، في الداتا كواليتي از ان ايفن، فعشان كده زي قصه البوليسيستيك اللي بياخد الليفر سيست بدل الكيدني سيست. في lacking of agreed standard of different centers، ودي مهمه، وده يمكن احنا يعني ده مكان نحب ان احنا بنجمع فيه كل سنه، فنحب نقول احنا نتعاون مع بعض عشان يبقى عندنا standards for this technology. وفي lacking of scientific verification and security and privacy of data. بتقف يعني قصه بتاعت جوجل والNHS دي وقفت عشان قصه البرايفسي بتاعت الداتا. at the same time كل الداتا دي بتيجي من retrospective study، واحنا عارفين ان الريتروسبكتيف دي من اضعف الستاديز، ما فيش مالتي سنتر ستادي الحقيقه قويه till now. الحقيقه انا بحب بس اشارككم ان انا I'm interested in that field، وعملنا conjoint work مع كليه الهندسه قسم كمبيوتر، and this is one of the studies اللي اتعملت. دي كانت رساله دكتوراه it is pending، هتتناقش قريب، ويمكن حد من حضراتكم هيجي يشرفنا ويناقشها. بيعمل الابلكيشن اوف artificial model ده في البريدكشن اوف intradialytic clinical events in end stage renal disease patient on hemodialysis، وده زي ما قلت لحضراتكم ده مع الهندسه قسم الكمبيوتر. This another model استخدمنا كيب أليكس داتا اللي يمكن الجمعيه المصريه كانت هي اللي لها الفضل ان احنا عملنا المشروع ده، وعملنا من الداتا بتاعتنا الارتفيشال انتليجنس ابلكيشن، وده كان جزء من رساله دكتوراه لدكتوره في كليه الهندسه، وعملت حاجه فيري سوفيستيكيتد اسمها الفازي اسوشيشن رولز. مش هطول على حضراتكم، بس يعني داتا مايننج وفازي اسوشيشن حاجات كده الحقيقه صعبه شويه، ودخلت الفاريبلز بتاعت الكوهورت بتاعنا وطلعت الجرافز ده. بس المهم الكونكلوجن بتاعنا ان في اسوشيشن ما كناش متصورينها قوي في حاجات احنا ما كناش حاطين في اعتبارنا، فقلنا لما نكبر السامبل احنا هنريفايز تاني these variables. يعني الاولد ايج مع البي ام اي العالي ده خد الجريتست، البي ام اي والهاي واللو كوليسترول قلنا لها ازاي يعني and so on. فبنقعد ندسكاس عشان زي ما بقول الستاندردايزيشن ده مهم. And they conclude that this is helpful. This technique is helpful in many practical situations، وممكن تغير الديسيجن بتاع الفيزيشن. And thank you very much.
Hala Al-Wakil for your elegant presentation. We are enjoyed from your elegant presentation actually. Many thank you.
Right, it is my pleasure and honor to introduce the next speaker, Professor Saadi. He is well known in Egypt and Africa. He have many positions. The latest may be the president of International Kidney Federation, and his topic is very important: management of diabetes in COVID. Please, Professor Saadi.
To be sharing the NephroShams 2020 prestigious meeting, and I am going to present the topic of management of diabetes mellitus with COVID-19. This is the agenda of my talk, and I'm going to start by the introduction and outcome of COVID-19 in diabetes. Various severe acute respiratory distress syndromes related to the coronaviruses have affected the human being, and all of them was having the reservoir as the bats. And many of the Chinese are still dealing with the bats, hunting them, cooking them, and serving them as food, and they are in very close contact with them. Also, they are in contact with the incidental host, the Malayan pangolin, and many of the Asian communities are dealing with these animals in a very easy way, and even the children are using them, and it is very possible that there is also a fecal oral transmission, and serious change is required to abort these deleterious outbreaks. Diabetes does not seem to increase the risk of occurrence of COVID-19. In meta-analysis in Chinese studies, the prevalence of diabetics among those who encountered COVID-19 was around 9.7%, which is a bit lower or similar to the prevalence of diabetes in the general population, which is around 11%. Also in Italy, the diabetics among the COVID cases was around 8.9, which is a bit less than the incidence of diabetes in the general population, about 11%. Actually, diabetes had no significant effect on the occurrence of COVID-19, either in presence or absence of chronic kidney disease. And the impact of diabetes on clinical outcomes, it was noticed that it would affect the severity of the disease, not its incidence. And the severe diseases are significantly higher in patients with diabetes compared to non-diabetics, 34% versus 14.2 in non-diabetics. And it was noticed that the survival of COVID-19 patients was definitely much lower in diabetics than in those non-diabetics, and the difference is highly significant. This can be encountered more in males rather than females, where the severe COVID-19 and the mortalities was much higher in males, being triple than the number of females. The severity of the disease is related as well to the number or the presentation of the angiotensin-converting enzyme 2 receptor concentration on the cell surface membrane, where it is in normal conditions allowing after internalization of the virus and reduction of the number of angiotensin-converting enzyme. It allows the metabolism of angiotensin 2 or excess angiotensin 2, and we don't get a severe disease. But in conditions where the presentation of the ACE2 cell surface receptors is reduced, as in diabetics or in other conditions with hypertension or aging or heart failure, the internalization and the reduction of ACE2 allows accumulation of angiotensin 2 with its deleterious consequences. It was noticed that the viral load is directly related to the level of blood glucose, where you can notice that the higher the blood glucose, the higher the viral load or the replication. Also, the available receptors for internalization are increased with the elevation of the blood glucose, so uncontrolled diabetes might increase the risk of cell infection and getting a severer disease. The SARS-CoV-2 replication is related to the process of glycolysis, where if you block the glycolytic process, you can get a countdown of the viral load or a reduction of the viral load, as you can see to the right of the screen. What is the impact of SARS-CoV-2 on glucose metabolism itself? It can be noted that the SARS-CoV-2 can directly damage the beta cells and can be related to the occurrence of new onset diabetes mellitus. And there is a general registry, international registry for detection of such cases, and it is called the COVID-DIAB or COVID diabetes global registry, as you can see in the square. It is very important to notice that the highest presentation of ACE2 receptor is in the gut or in the colon. It is 200 tags per million receptor of the cell surface receptors. And you can consider that the occurrence of diarrheas and gastrointestinal manifestations to be more frequent. And the manifestation in the lung, although being much severer, yet the ACE2 receptor is not that much as in the colon. And you can notice that in the pancreas, the representation of the ACE2 receptor is minimal. So the possibility of getting the direct destruction of the beta cells is not a very frequent complication. The viral or the non-structural protein of the virus, particularly NSP13, directly affects the insulin signaling process and decreases the production of insulin, even if it does not result in destruction of the beta cell as a whole. The metabolism of the SARS-CoV-2 results in the production of hypoxia-inducible factor, and this induces the glycolytic genes, which are directly responsible for the cytokine storm. And targeting hypoxia-inducible factor may have a great therapeutic potential for the development of novel drugs to treat COVID-19, particularly its complications, rather than the infectivity or the infection by the virus. Here you can notice that an inhibitor of the hypoxia-inducible factor would die with SARS-CoV-2 is the ACE2 receptor. But we can notice that it is known that immune cells do not express the ACE2 receptor, and it has other receptors, including the CD147, which is called the bassigene, is the main receptor for the CoV-2 in T cell lines. And you can notice that its main transmembrane partner is the CD147, is the GLUT1 soluble carrier 2A1. And the CD147 has various co-partner molecules, including cyclophilin, which is a target of cyclosporin, and its activating trimer is CD44, and it uses the cofactor to introduce into the cell the integrins. So the CD147 and the integrins are the main receptor in the immune system. In the meantime, it was noticed that as in Plasmodium falciparum, azithromycin, which is known as the Zithromax, is known to block the CD147 and block the infection with malaria. And inhibitors might reduce the introduction of the virus into the cells, and it would reduce as well the pro-inflammatory cytokine response. And the control of hyperglycemia itself might reduce the viral entry as well. There are potential harms of using the GLP-1 receptor agonists because it stimulates the angiotensin converting enzyme, and this would increase the viral load, but this is still speculative rather than documented. The glucose-related protein chaperone is mainly encountered, as you will see in the blue circles now, mainly in the endoplasmic reticulum. It does not represent in the cytosol or in the cell membrane or in the nucleus, except rarely. In the endoplasmic reticulum, it is related to the protein folding and the structural integrity of the endoplasmic reticulum functions. It might be also present in the mitochondrial metabolic pathways, and it controls the calcium homeostasis and energy balance regulation. It's also represented, but minimally, in the nucleus, where it is related to DNA damage protection. It might be also represented in the cytosol, where it is related to the inactivation of the tumor suppressor gene P53. It is rarely represented on the cell surface membrane. So this glucose regulatory protein, when it is present in the cell surface, it might be related to gross signaling and an angiogenic signaling. It is rarely secreted, and it might be related to activation of the innate immune adaptive response. In stress conditions, it is highly upregulated on the cell surface, as you can see in this cartoon. And the co-localization of the DPP4 with the GRP, the glucose regulatory protein, is an important factor, particularly when it is upregulated. There are also concerns of various drugs during COVID-19, where some medications have no much concern, but with, for example, pioglitazone, liraglutide, and the sodium glucose transporter inhibitors, there is a theoretical risk of poor outcome. However, no data are present in humans about this, and some opposite data might be present, as I will demonstrate in the coming slides. DPP4, as I explained before, might be beneficial, and particularly its anti-inflammatory role. Hydroxychloroquine, which is frequently prescribed to reduce the infectivity of SARS-CoV-2, is a known hypoglycemic agent, and it can also be an add-on drug in such situations. The antidiabetic effect of chloroquine was first described in 1984 in a patient with severe insulin resistance, in whom the addition of chloroquine dramatically reduced the insulin response. It probably decreases insulin metabolism and is a potential. It's a potential to enter as an antidiabetic agent. The interactions with the COVID-19 treatments, the interaction with the hypoglycemic agents. Metformin, DPP4 inhibitors, and the SGLT2 inhibitors might interact with lopinavir and ritonavir. Also, sulfonylureas might also react with these two agents. Sulfonylureas and insulin might interact with hydroxychloroquine. Both of them are hypoglycemic and might induce hypoglycemia. An important outcome of using the metformin. And in a retrospective analysis, it was noticed that those who are maintained on metformin has a much greater response to the COVID-19, where the response was much better, and the hospital mortality was much lesser than those who are not receiving metformin. And it's considered to be a candidate for the host-directed therapy for COVID-19. This is particularly noticed in women rather than in men. So this beneficial effect of metformin is considered to be beneficial and significantly beneficial in women, but it was not similarly encountered in men, and you can encounter even worsening in some male patients. Also, the tumor necrosis factor inhibitory response was encountered as well to be much reduced by the use of tumor by metformin. The GLP-1 receptor agonist, the DPP4 inhibitors also, as I mentioned before, might reduce the infection severity. The SGLT2 inhibitors in severe cases might be withheld, but the GLP-1 agonists are considered risky and should be suspended. An important issue of the dapagliflozin is noticed in the situation with COVID-19 infection, where in such cases there is an associated low cytosolic pH and the NH exchanger, sodium hydrogen exchanger activation is generally affected, and you can develop with the production of anaerobic conditions, you can develop lactate formation and lactic acidosis. And dapagliflozin directly inhibits this N-sodium hydrogen exchanger and prevents lowering of the cytosolic pH. So this is a beneficial effect of the SGLT2 inhibitors and can be reported to reduce the lactic acidosis. So it is cytoprotective. Structure protein 14, and it is frequently considered one of the most important drugs to be withdrawn in patients under immunosuppression, but we should revise this approach, and at least we can reduce the mycophenolate rather than stopping it as a whole. Also, several agents are important binding sites with these protein-protein interactions. Also, the endobisacin is considered one of the important binders for the NSP7, as well as the tacrolimus, which can bind to the open region frame 8 region. There are various studies now evaluating the effect of dapagliflozin as a therapeutic agent for COVID-19, and the data will be released by December 2020. And these are the clinical trials which are awaiting the data by the end of 2020. So this is an important aspect of repurposing of the SGLT2 inhibitors, which were previously considered as harmful in COVID-19, but they might have beneficial effects in such cases. The docking energies, which is the easy binding process of different agents, can explain their binding activity and reducing the entrance of the COVID-19 or the receptor. Here we can notice that imatinib, which is an important chemotherapeutic, can easily bind to the monoamine, the activated adenosine phosphate kinase, and results in binding of this molecule and reducing its infectivity of the virus. Losartan, which is one of the ARBs, is also an important binder, and also you can notice that hydroxychloroquine binding is very weak, so it is not an important aspect. That's why we can encounter many data explaining the weak effect of hydroxychloroquine in getting rid of the viral load in SARS-CoV-2. And you can notice that vitamin D is much beneficial in that aspect. It's also important to consider that there are various studies now on inhaled biguanides and mTOR inhibitors to prevent the SARS-CoV-2. At last, Mr. Chairman, we can notice that the diabetes mellitus increases the severity rather than the incidence of COVID infection. And SARS-CoV-2 would induce new onset diabetes mellitus, although this is not very frequent and it's under registry. We should consider maintaining the current hypoglycemic agents in patients treated as an outpatient. We should guard against dehydration and ketoacidosis in hospitalized cases. Insulin therapy is to be considered in severe cases as the main hypoglycemic agent, with frequent monitoring of blood glucose, and DPP-4 inhibitors would reduce viral entry, and protein-protein interaction maps demonstrate potential benefits of metformin and sodium glucose transporter inhibitors. Thank you very much for your attention.
Gamal Saadi, the professor of nephrology, Cairo University, for this lovely presentation and the important informations in this lecture. And we are going now to discuss some questions related to the previous topics. And we are going to start by the professor, Dr. Gamal. Dr. Ahmed.
We are going to start lecture by lecture. So I have a question to my professor, Professor Adil Afifi. What are the differences between the other viral nephropathies in comparison to COVID nephropathies as regards the pathogenesis and the treatment? I know that this COVID glomerulopathy, whatever, is a very recent, so we don't have any data. So do we have a difference in pathogenesis or management?
I'm not sure about this, Ahmed, actually. There are many unknown things about this COVID-19 viral infection till now. And many of the papers I showed you are showing equivocal results, actually. So you cannot actually compare it with the other known viral infections of the kidney. I think it is a unique form of viral infection, and it has a very severe renal infection, actually. And there was one recent paper from the United States just 2 or 3 days ago showing the incidence of acute kidney injury to be about 76% of patients who are admitted to ICU, and about 1/3 of these patients would require dialysis. So it seems actually a little bit different from other known viral infections, CMV, hepatitis, and so on.
I have a question, Professor Adil, also regarding the second wave. We are now witnessing another presentation, the GIT presentation of COVID. Would this change or increase the incidence of AKI in patients with COVID or not? This is the first question. The second one is, what is the outcome of post-COVID AKI? Is it more more worse or less worse than other causes of AKI?
A very smart question, Magdi, actually. The first part of it, I mean. Can you repeat it again?
The first part is the second wave with GI manifestation.
Okay. Now, this is GIT manifestations is a very strange manifestation. But let me remind you that it was present even in the first wave. And the first patient, who is a Chinese doctor who had COVID infection at the start, died actually from severe diarrhea. So it is not new to have this kind of GIT infection. And indeed, what is said now is that this COVID-19 virus is a mixture of two viruses, one of which is the asprovirus, which is a GIT virus causing fever and diarrhea, and the other one is the SARS virus, which is causing these symptoms. So that's why we are getting actually both manifestations of diarrhea and chest infection. So I think that the second wave is not only diarrhea, it was present also in the first phase. What was your second question, Magdi?
What is the outcome of post-COVID AKI? Would it be expected to be worse than other causes of AKI or the same? How many patients will be on regular dialysis afterward?
Nobody knows so far.
Okay.
Dear Professor Adil, nice to meet you. I have two questions from audience about your experience regarding mortality in end-stage disease patients who are in hemodialysis and having COVID-19. This is the number one.
There is increased mortality in these patients. And we have seen a lot of patients die from COVID-19 who were chronically on dialysis. This is well known, documented anywhere. So there is increased mortality.
Second question about the role of plasma viruses in COVID-19. Will it help in removing antibodies against coronavirus?
There is no literature about plasmapheresis in such cases. What is actually there is
خلاص كده الدكتور بقى نقلب على الدكتور.
using high cutoff membranes. These high cutoff membranes, which have very wide pores, can remove those cytokines, particularly those responsible for this storm, and you can remove them by these high cutoff membranes or even medium cutoff membranes. They can be very useful. They are actually used mainly now in multiple myeloma instead of using plasmapheresis. So they have replaced actually plasmapheresis in the treatment of multiple myeloma. And they are very promising actually in removing the cytokines which are responsible for the cytokine storm.
تمام. اشكره بقى.
Many thanks, dear Professor.
Okay.
Professor Hala? Do you have Professor Hala with us? Thank you very much, Professor Hala, for your presentation. I like it. It was very smart. And I think COVID-19 reshaped medicine. So we use telemedicine by different aspects. Even at our center, we replaced our daily morning meeting by teleconsultation on a special group. So I think using telemedicine, artificial intelligence, and all these aspects, these are one of the advantages of COVID-19. So I think it will be left forever. Some of these activities will continue with us after the end of COVID. Thank you very much.
I would like to add something, Professor Shaisha, that one of the pioneers in the field of artificial intelligence was Aql, Ahmed Aql, and his publication الحقيقة يعني ما حطيتهاش عشان الوقت بس الحقيقة المنصورة كان لهم شارك very premature في قصة الارtificial intelligence وانتوا دايما سباقين بالخير يعني. Thank you very much.
Regarding the artificial intelligence and the work of Dr. Aql, he did this job in the hemodialysis since 2001, so 20 years now, and we repeated it in the oncology, in urology, uro-oncology. So it seems this is the language of the literature to use artificial intelligence, because even if we depend on multivariate analysis, this will create a good way, but artificial intelligence can create unlimited number of association, and we taught a lot from the artificial intelligence and to know how to assess and how to predict the problems in our patients.
Dr. Hala, I have a question about the ethics of using telemedicine in diagnosing and treating patients, especially those who you don't see and you don't know. What do you think telemedicine can do in such conditions?
هو دي الدايلما حضرتك يا دكتور مجدي.
Professor, can you speak in English, please?
Okay, this is one of the great challenge of artificial intelligence, and this handle its use at a broad scale. And as I mentioned, the Google and the NHS from England stopped because of these issues, because the private sector use this data for some commercial aim and purposes. For that reason, there was a stoppage of this huge mega project. Because the same point you elegantly mentioned, until now the ethical regulations and the rules are not settled yet in all these fields of telemedicine and the data management and the data boring and all these issues are not settled yet.
And I'd like to just to add a point here in telemedicine. Every day there are many progresses in this issue, to the extent that we can evaluate the patient while he is very far, through using different technologies. I can hear his heart sound while I am in my office and he is in his home. So because every day technology is progressing. So I think this is very nice because it stimulates how to produce this technology, how to use it. So this is the life changing. Everything is changing.
And this is also, Professor Magdi, is a point of great research, what is known as network security. My cousin in USA, she's engineer and she's very interested in that issue. It was a lot of regulations was put for these issues, but not settled yet. Yani, it is a point of research till now.
Yes, because if you prescribe medication to a patient without seeing him, without knowing the exact problem, especially in medicine, this might cause trouble for the patient, and also it might put you into
legal issue.
Yes, a legal issue. This is a legal issue in medicine, and we are all faced by legal issues and legal complaints. So yes, I agree with you. We still in need for legislations and regulations about this telemedicine.
Yeah, I totally agree.
We have a question also, Professor Hala. We need a big data system, both artificial intelligence and the human tab on each of this field, not only just the artificial intelligence. So what do you think about how to deal with these big data systems?
Look, Dr. Magdi, we are still very premature in that field because we are, we have to depend on electronic data system and data records, so as to start all these work. Unfortunately, still we our far from these electronic patient records. يعني our concern at the level of university and digitalize our data so as to manage our data without being registered, without being recorded and documented. Nothing will be done and no advances will be done. For that reason, the ESN was encouraging all the people for the registry, for the data entry, for all these issues, so as to start to work. We are still now very far from all these issues. But first we have to collect our data, and our data should be clean data, because rubbish in, rubbish out, and we should encourage all people to be honest and to be sincere and to be patient in introducing the data, because we all will get benefit from this data management afterwards.
Okay.
Thank you, Professor
Hisham.
One question from the audience to Dr. Gamal Saadi. He is asking about the safety of the DDP4 inhibitors in the patients with COVID-19, and can we use it or not?
I believe the DPP4 inhibitors is one of the very important tools to prevent the viral entry, because in the immune cells, the receptors are not the ACA2 receptors, but it is related to the CD147 and the CD26, which is the DPP4 itself. So blocking the DPP4 by the inhibitors would prevent the viral entry into the immune system. So it's a very important tool to avoid cell infection. It is very beneficial to be using them, particularly in those who are treated as outpatients. Probably in severe cases and in critically ill patients, the only line of treatment for hyperglycemia would be the insulin.
All right, Professor Saadi, can I ask you a question? You have already illustrated the interactions between COVID and diabetes. My question is how this will determine your management differently. What I mean, can you treat COVID in diabetic versus non-diabetic differently? And can you treat diabetes or diabetic patient if they got COVID different than diabetes not with COVID?
Actually, when we are treating diabetics who encountered COVID-19, it is very important to segregate the stage or the severity of the disease and to choose the hypoglycemic agent suitable for them. Many of the agents now are having beneficial effects by docking. Docking means binding to the either the receptor or the spike of the virus. And this is a very important issue to avoid the trimming of both of them or activating both of them to allow binding and viral entry. Many of these agents bind to particular sites of the spike or the receptor, and by that way they avoid activating the process of entry. This includes metformin, this includes SGLT2 inhibitors, this includes as well the DPP4, which in addition blocks the actual receptor on the immune cells. This is an important issue in the process of management. In cases who are not diabetic.
Saadi, maybe I wasn't so clear. From the practical point of view, a bedside management, shall we increase doses of some drugs using in COVID in diabetic? Shall we change or remove ones? At the same time, anti-diabetic treatment, shall we remove some if they got COVID? Shall we increase the dose? Just a practical point to use it just right now.
For diabetics who are treated with the primary agents, we should not change the treatment. We should monitor against excess hyperglycemia because this is related to viral replication. We should benefit of the agents which have a beneficial docking effect. Probably the GLP-1 inhibitors are to be avoided if anyone would encounter COVID. But sulfonylureas have no good or bad effect. It is very important to consider choosing the agents which are of benefit, particularly the DPP4 inhibitors, the metformin, and an important issue to maintain a patient who's diabetic on SGLT2 inhibitor is that he should be receiving in the meantime an angiotensin receptor blocker because its beneficial effect is directly related to the combining of these agents with the ARBs itself.
Professor Saadi, thank you very much. Regarding the issue of monitoring of glucose after treating the patients by anti-hyperglycemic drugs, do you find continuous glucose monitoring a good strategy in COVID patients with diabetes?
In critically ill patients, this is mandatory, Professor Hussein, and thank you for the question. But outpatient cases, probably we don't need a continuous monitoring, but more frequent monitoring is important.
Okay, thank you.
Professor Gamal, I also have an inquiry about what are the most likely drug to stop in patient with COVID-19? Would you stop any kind of oral hypoglycemic medication or insulin? Would you? Is there any recommendation for this?
I would repeat myself again. We should segregate between those who are treated as an outpatient and those who are critically ill in the ICU. For outpatients, I would prefer not to use the GLP-1 agonists. Because they might be harmful because they would potentiate the DPP4 receptor, which increases the viral entry to the immune system. It is preferable to choose the agents which are beneficial in combating the viral entry and the viral replication, including the metformin and the DPP4 inhibitors. It's not very wise to keep a patient on sulfonylurea. Insulin therapy would be only used in critically ill patients.
So would you recommend to stop sodium glucose transport inhibitor in patients who got COVID and not hospitalized?
I would not recommend doing this at all. I would prefer to maintain, because recently it was encountered that it might have a protective effect by docking to the spike of the virus, and its beneficial effects, as I mentioned a while ago, that it is beneficial with the ARBs angiotensin receptor blockers. They should be, both of them should be prescribed to the patient. But if the patient is not receiving an ARB and he's receiving an SGLT2 T2 inhibitor, I would prefer to stop it.
Okay, thank you very much, Professor Gamal. Very illustrative presentation.
Yes.
Thank you very much.
Shall I ask Professor Adel Afifi if we don't have... Professor Adel Afifi, are with us?
لا خلاص.
All right.
Okay.
احنا خلاص كده يا جماعة.
Okay, thank you very much. And this concludes this session. We have the next session soon. Stay with us. Thank you.
بسم الله الرحمن الرحيم. في البداية أحب أشكر الأستاذ دكتور مجدي الشرقاوي واللجنة المنظمة على استضافتي للمحاضرة دي، وبشكر أمجن who helped me a lot in arranging this presentation. Our talk today is anemia management in CKD patients. But what is different now that we are talking about in era of COVID-19? This is our agenda, starting with some facts about anemia in CKD patients that is associated with increased hospitalization and mortality, increased burden of cardiovascular disease, as well as the reduced quality of life. What are the challenges in anemia management that is sometimes is a nightmare for a nephrologist? Our target is to correct hemoglobin, but of course, the target hemoglobin is not an easy task. We have to combat all the challenges that is facing the nephrologist in this long road of management of anemia. The patient outcome is our goal, but sometimes the patient outcome is not a good guy. We have to optimize the action of the ESA used. We have to use the right ESA for each patient. Also, the iron should be improved, the use of iron, as well as the repletion of the iron stores should be done. The hemoglobin target is not an easy goal, because we have to maintain this target. We have to customize it for each patient according to each patient scenario. And we have to maintain and stabilize this target level all the time. And I will start with this point. The fluctuating hemoglobin is not an uncommon event. It is a common event that occurs in majority of our patients. And in this elegant study, they found that the only reaching target hemoglobin constitute only 6% of their cohort, and a lot of patients, around 30%, are low amplitude fluctuator, whether to the high level or to the low level. And also a great majority, which constitute around 40%, are high amplitude. So this is not uncommon scenario abroad as well. And at the national level, when I revised my own data in Marseille University Hospital, I get a snapshot for 3 months, and I found this fluctuation quite evident. Not only a university hospital, but this is an elegant private hospital in my city, and only those reaching the target are 45%. Apart from the same ratio are fluctuating. Also, Al-Minshawi and his group in Minyan, as a part of Upper Egypt, also found this fluctuation in his unit, and this was evident in this figure. So the fluctuation is not a nice thing, because it is associated with a great mortality. The other channel is that our patients are sometimes below target hemoglobin, and this is found in locally in Egypt in this very nice, elegant study in Manufia by Zorqani, our colleague. He found that among his cohort, which is large cohort, he found that the mean hemoglobin is below target. Again, our data, and I have to thank the board of the SRD registry board, led by my dear friend, Professor Maha Sabala. She did a great work in getting these reports. And our cohorts at the national level also only around 40% of our cases only reach target. This is the green part of this bar. Apart that, the majority of our patients are using ESA. So what is the problem? Is it, and this could be associated also with the cardiovascular and the intradialytic hypotension that may occur with our patient. So what is the problem? Especially that the lower hemoglobin is associated not only with this morbidity, but also with a great mortality. The other challenge, that the long time to reach a target, is another challenge. And this elegant study found that when we spend a lot of months or the long duration to reach the target, when it increases, there is increase simultaneously the mortality, which is a red bar, as well as the hospitalization, which is a gray bar, with increasing the time to reach target. In another study, they found that and this constitutes around 30,000 of patients, that the mean months to reach target hemoglobin was 1.3 months, and they found that a large proportion of their patients, around 40%, reached this target in more than 1.3 months. And this was associated with more hospitalization, and this was significant, and more mortality, and this is also was significant. Another challenge facing the nephrologists is that our hemodialysis patient has an eventful patient. He has a lot of events, intercurrent events. During dialysis session, we may confront it with clotting, with blood losses, with hypotension, with fistula bleeding, a lot of issues. And also between dialysis, there are another constellation of complaints. So all these constitute almost around 8 events per patient per month. So our patients is not stable patient. So we need, for that reason, a flexible erythropoietin, and we should be, all the maneuvers should be very flexible. This is in general. What about in COVID era? In COVID era, we have a lot of challenges, more added to the previous challenges. Let us revise these challenges and solutions. In this COVID, we advise our patients for fewer visits, for minimal interaction with the healthcare workers. And the solution for this is the home management and the telehealth, as we are using some of this technology in this e-conference. Another challenge that the change in logistics of hospital and policy, this should be corrected or solved by longer period of checkup of our patients. And for that reason, we may manage our patients every 3 months instead of every month. And so we need a longer half-life of erythropoietin with lesser doses. Is much preferred for this scenario. Talking about the short and long acting ESA, this is a very well established data. But when we are talking about long acting ESA, we are confronted with the darbepoetin, as well as the Mircera, but the Mircera are erythropoietin receptor activating agent. It's not a mere erythropoietin. So when we are talking about erythropoietin, the short acting are the alpha and beta, and the long acting erythropoietin, this is the DARB. And there is a global erythropoietin drug market all over the world, focusing on the darbepoetin, which has a very long half-life, reaching more than 70 hours, and with extended dosing schedules. And this additional carbohydrate moiety is the purpose for making this molecule have a long life in comparison to the alpha and beta. So what is the ESA of choice for your patient and why? Of course, you have to tailor each ESA for each patient. It's not a mere like one solution, because not all fit all. So we have to discuss some of these character of our erythropoietins. What about the dose penalty when administered subcutaneously and intravenously? This is a comparative study between the alpha and the DARBA. Now, when we shift the black and gray, this is for the recombinant erythropoietin. When we shift from intravenous to subcutaneously, we lose around 30% of doses. While the darbepoetin, no changes when shifted from intravenous to subcutaneously. And this also gives the same idea. The no-dose differences with aranesp or with darbepoetin in the two modality of administration. And this is quite evident that the erythropoietin, short-acting erythropoietin, you will lose this great majority, a great ratio of doses, which may reach to more than 20 or 25%. So what about the dose saving after switching from erythropoietin short-acting to long-acting erythropoietin? This study found that when we convert from short to long acting erythropoietin, we are saving at around 30%, and this is more evident with the higher doses of erythropoietin. And this meta-analysis is a very elegant meta-analysis, gives us this figure with 30% dose saving when we shift to from short-acting to long-acting erythropoietin. And the reverse, we have to add more 15% of the dose when we shift from alpha erythropoietin to biosimilar EPO lambda, which is not present in the Egyptian market. The dose conversion ratio is a point of research in multiple studies, and they found this ratio around 300 or more. This is different from the 200 to 1, which is a peptide mass equivalence. And this is an elegant study that answers the question of the dose conversion ratio. It is a post hoc analysis and give us this round figure that is used for our country in the Ministry of Health. What about when we switch to DARPA? What about the dose and the response? We found that when the long-acting erythropoietin is used and followed for 12 months, the 100% all our patients reach the target. In comparison to only 70% of the patients used the epoetin reach the target, and leaving 30% not reaching a target. So we are saving money, but are we offering effectiveness? This is well shown in the next slides. The extended dosing of long-acting erythropoietin, this is shown on this large cohort of 6,000 patients using the darbepoetin for more than for 1 year, and they show almost stable level of hemoglobin as well as stable level of international units of erythropoietin, darbepoetin. And this is another study using a smaller number, and they show the same conclusion of the stability of the hemoglobin as well as the stability of the dose. Again, this is shown not only on the naive, but also on the prior use. When they are used short-acting prior to the darbepoetin or the darbepoetin long-acting, the stability in the hemoglobin as well as in the dose is shown for the 72 months, and in the naive group, the red spots or the red line is showing the stability of the hemoglobin, and the green line show the stability of the dose. So we are getting the same effect with a stable hemoglobin without great fluctuation or no fluctuation, with a stable dose of erythropoietin without increasing the dose. Another challenge, or another, benefit to the use of this long-acting erythropoietin is the operational efficiency. Does it mean? It means that we are not saving doses, but we are also saving an operational effort. That is that is to say the minimal storage, the minimal usage of exposure to patients with the healthcare provider, the lesser work, the lesser use of refrigerator, the lesser everything is calculated, and this is, by the end of the day, is calculated as operational efficiency gain, and this will add to the dose benefit. So by the end of the day, we get this saving. Again, we can individualize this drug to each patient. And this table shows elegantly that the long-acting erythropoietin, the darbepoetin, can be used per week, either intravenous or subcutaneously every 2 weeks, by the two routes as well, and also by every 1 month, but also only with a subcutaneous dose. The intravenous dose is not used anymore with the monthly dosing, in contrast to the other erythropoietins. So, Mr. Chairman, ladies and gentlemen, I can conclude that the half-life of darbepoetin allow extended dosing schedules and customized control of hemoglobin. Its use in COVID-19 era is very convenient. 30% overall dose saving achieved in CKD patients switching from short-acting ESA to darbepoetin alpha. There is no difference in intravenous subcutaneous dose requirement for the darbepoetin alpha, and the conversion ratio higher in clinical practice, potentially leading to greater dose and cost saving. And there are this less frequent dosing provide a great operational efficiency. And thank you very much.
MSD, for giving me this opportunity to share in the Cardiometabolic Summit of the Egyptian ADC. My presentation today is about combination therapy for dyslipidemia after the late guideline. This is maybe a solution for a new challenge. Why should we care about dyslipidemia, especially LDL cholesterol? Because we know that atherosclerotic cardiovascular disease is associated with increased mortality. Every 4 seconds, someone dies from MI, from myocardial infarction, and every 10 seconds, someone else dies of ischemic stroke. And the incidence of cardiovascular risk, especially MI, in patients with diabetes is markedly increased in both men and women versus normal population. This shortens their life. And also, acute coronary syndrome has a very high rate of incidence in patients with CKD. It's almost 100 times in patient in stage 1 CKD, which is normal creatinine, and 400 times in patient with CKD stage 5. This is 400 times than the normal population. And that's why we say that diabetic patient, if they have cardiovascular disease, they lose of average 12 years of their life if they are not diabetic. And if they don't have cardiovascular disease, they lose 6 years of their lives. The major cause of mortality in diabetes is, of course, cardiovascular. And this is exactly the same situation in patients with CKD. Even as early as stage 2 and 3, in men and women, they lose years of their life. And the mortality in dialysis population is by far much worse than in non-dialysis population. And combining diabetes and chronic kidney disease multiply the risk for coronary heart disease, and so we call them risk multiplier. Diabetes and CKD both increase the risk of chronic kidney disease. And dyslipidemia is at the heart of the 3 major cardiovascular risk factors, which are the non-communicable diseases: diabetes, hypertension, as well as chronic kidney disease. Dyslipidemia is there in most patients. And in diabetic patients, they have another bad factor, which is the small dense LDL particles. In diabetics, they don't have the normal LDL configuration. They have the small and dense LDL. And this is glycated LDL, which occurs after exposure for a long time for hyperglycemia. This is the atherogenic LDL, which causes the initiation and the growth of the plaque. In chronic kidney disease, again, the size and the density of LDL is small. And these smaller dense isoforms are very atherogenic. And that's why, while LDL is not usually elevated in most patients with CKD of different stages, but small dense LDL is extremely common and very high in patients with chronic kidney disease. And that's why the resemblance between diabetes and chronic kidney disease. So what about management? How far should we go in lowering LDL? This is a very important question, because we know from the old studies that decreasing LDL is associated with decreased cardiovascular mortality and the major cardiovascular event. This is a CARD study also stating the same. Using atorvastatin reduced the risk of primary and cumulative hazard of primary endpoint. And this occurs in elderly as well as in young people. And all studies, the ATP, the CARD study, stating clearly that reducing LDL reduces the primary endpoint like acute coronary event, coronary revascularization, and as well as saying that in normal population as well as in diabetic population. The CKD population was also studied. This is a meta-analysis of 26 randomized trial, including 170,000 patients. The cholesterol treatment trials, it showed clearly that reduction of LDL reduces the cardiovascular mortality and reduces the incidence of heart attack, revascularization, and ischemic stroke. And this occurred with GFR above 90, 60 to 90, as well as less than 60. So there is evidence that it also protects the patient with CKD. And this is a TNT trial treating to new target with atorvastatin, again showed 32% relative risk reduction of major cardiovascular event in patients with chronic kidney disease. And in this meta-analysis of 19,000 patients showed benefit of reducing MACE and acute coronary disease in patients with CKD 1, 2, and 3, but in stage 4, the study was not powered enough to reach conclusion, and in stage 5, there was no benefit of using statins in this patient. And recently, all other studies have shown that using statin or ezetimibe or PSK, especially in patients with higher LDL, reduces the risk of cardiovascular. That's why in 2017 it was suggested by the American Association of Clinical Endocrinologists and the American College of Endocrinology to go down with LDL to less than 55 in patients with high risk. Those with progressive atherosclerotic cardiovascular disease, those with diabetes and chronic kidney disease, especially stage 3 and 4, and those with history of MI or premature atherosclerotic cardiovascular disease. And that level at that time was a new paradigm. And again, the American Association of Clinical Endocrinologists have stated going down as far as less than 55 in patients with high risk, and they graded A for this guideline. And finally, in 2019, the European Society of Cardiology, European Atherosclerotic Society guideline have approved this, especially in patients with high risk, those with diabetes, those with chronic kidney disease. If they have CKD 30 to 60, they considered high risk. If their GFR is less than 30, this is a very high risk. And in patients with very high risk, we have to reduce LDL to less than 55. And in patients with high risk, we have to reduce to less than 70. And this is what happened. This is the shift of the target, especially in patients with a very high risk group with diabetes. And more recently, in 2020, in diabetes guideline, the ADA guideline, they have stated that we have to reach this target, and they suggested not only using statin, not only using high-intensity statin, but also using ezetimibe to reach this target easily and less expensively. And what is the high-intensity statin? Those statins that can bring down the LDL to more than 50% of its original level. And that's to say we have either to use atorvastatin or rosuvastatin, because these drugs are the approved high-intensity statin, atorva at dose of 40 and up to 80, and rosuva dose of 20 and up to 40 milligrams. And also in European Society of Cardiology, in 2019, they recommended to use the high-intensity statin to the highest tolerated dose to reach the target, the new target of LDL of 55 in very high risk and 70 in moderate in high risk patients. And also, if this target cannot be achieved, they recommended using combination with ezetimibe. And this is class 1B recommendation, which is a very good recommendation. And combination therapy will serve to reduce the dose of statin used, reducing the dose-dependent side effects, and also will reach the target LDL level smoothly. And we may have proof of that. It's now time to think beyond statin monotherapy. Ezetimibe is a well-known class of medication that, together with statin, reduce the hepatic cholesterol, increase LDL receptor expression, and increase clearance of plasma LDL cholesterol. They don't work in the liver, they work mainly in the intestine. And to prove the concept of ezetimibe, this study was done on elderly Japanese patients using just ezetimibe alone, published in American Heart Association 2018, using either dietary consultation or dietary counseling with ezetimibe 10 milligram. And the result showed ezetimibe plus diet compared to diet alone significantly reduced the primary endpoint by 34%. And LDL cholesterol at baseline was 161 milligram per deciliter, reduced to 120 and 131 milligram in ezetimibe and control group, respectively. So it showed very good effect even without statin. So what about if we use it with a statin? This is the EZ-PATH study comparing using ezetimibe with 40 milligram atorvastatin versus atorvastatin 80 milligram in patients with hypercholesterolemia. And this is a study design, and astonishingly, the reduction with 40 milligram atorvastatin with ezetimibe was significantly lower than using 80 milligram atorvastatin alone. And 74% of patients using the combination of atorva and ezetimibe reached the target LDL below 70, while only 32% in the atorvastatin 80 mg reached the target LDL. But what about the clinical outcome of combination therapy? Not only the LDL cholesterol. We have proof, this is an improved study showing extra 24% reduction of LDL cholesterol adding ezetimibe to atorvastatin, and 6.4% relative risk reduction in the primary endpoint, including cardiovascular death, MI, and stroke. Myocardial infarction was reduced by 24%, ischemic stroke by 39%, and cardiovascular death, MI, or ischemic stroke by 20%. And in patients with CKD, this is a sharp study showing that reducing LDL further with ezetimibe have resulted in improved cardiovascular outcome in patients with chronic kidney disease. So can we use this combination therapy, which is high-intensity cholesterol lowering therapy, instead of high-intensity therapy alone? The answer came from IMPROVE-IT, in which using ezetimibe with atorvastatin have reduced LDL cholesterol by 65% if we compare it to moderate intensity statin or high intensity statin, and it is comparable, if not better, than using PCSK alone. If you want to go further, you can add statin to PCSK9, but this is an expense of a lot of money. And recently, the PRECISE IVUS trial studying the impact of statin ezetimibe combination on coronary atheroma plaque in patients with and patients without chronic kidney disease. This is a sub-analysis of this study showing that in patients with CKD, 52 patients, statin alone versus dual lipid-lowering treatment showed significant reduction in the atheroma progression. And in non-CKD patients, it's almost the same. So this combination is good for both patients with and without chronic kidney disease. And this was the conclusion of this sub-analysis. They stated that as with non-CKD, intensive lipid-lowering therapy with atorvastatin ezetimibe demonstrated stronger coronary plaque regression effect even in patients with CKD compared with atorvastatin monotherapy. And maybe this is a game changer in the way we treat patients with diabetes, with atherosclerosis, with dyslipidemia, and even in patients with CKD, because again, in this very recent study, last year's study, showing that it is also cost-effective to use combination therapy, atorvastatin ezetimibe, in patients with chronic kidney disease. So in order to summarize and conclude, LDL cholesterol remains the primary target of therapy in most strategies of dyslipidemia management, and even lower LDL cholesterol is better, especially in patients with very high risk, and addition of ezetimibe to atorvastatin provided well-tolerated, effective lipid-lowering therapy for patients with high risk and very high risk of cardiovascular disease. And in terms of cardiovascular outcome, ezetimibe to reduce LDL cholesterol have proven cardiovascular benefit up to 15% relative risk reduction in acute coronary syndrome patients with diabetes. And in EasyPath study, ezetimibe atorvastatin resulted in superior LDL cholesterol lowering, the goal attainment versus doubling the dose of atorvastatin. And as I have shown that also in CKD patients, it is effective and cost-effective therapy. Thank you.